acetylcholines, and you get, boom, a really quick increase in heart rate. I really should read ahead. At the onset of exercise is rapid PNS withdrawal, which increases heart rate up to 100 beats per minute. What if you want to change heart rate more? So sympathetic nerves contact both the SA and AV nodes as well. As exercise increases, sympathetic stimulation causes release of norepinephrine onto the heart. So again, now we're pressing on our gas pedal, which increases heart rate, as well as the force of myocardial contractility by increasing those nodes. So your parasympathetic is just affecting your heart rate. So it's just a straight up affecting the firing rate of the heart. Sympathetic also does that, but it also increases contractility. So contractility is the force with which the heart pumps. So you have your balloon. Oh, you're trying to like deflate balloons at a party. Party's over. Yasmin's going home. Want to get, when you're not popping a balloon, you, for some reason, untie your balloon and you're just waiting for it to, this is a terrible analogy. But obviously you could, like a whoopee cushion. You guys play with whoopee cushions when you were little? Yeah? And like you try to set it up, it doesn't work, now you have to get the air out. So you can like let it deflate out slowly, or you can apply some contractility to it and squeeze the air out, which is going to happen faster. Ooh, or an air mattress. Someone comes over to your house and it's crashing on your air mattress, you want to get it out. There's always that one hungover person that like dives onto the air mattress to let all the air out. It's a good friend. Okay, so sympathetic nervous system will increase myocardial contractility. And then it's responsible for increasing heart rate above that 100 beats per minute. Is everyone cool with that? Is it good times? Am I better at teaching the neuro stuff? Probably. Okay. Okay, so obviously these are going to affect heart rate. This is the way that we're affecting heart rate. Not so much contractility, but what about stroke volume? Oh no. Oh boy. Okay. So stroke volume, and remember, sorry to do this one more time, heart rate is the thing that we can change from rest to exercise, yada yada, but like someone who's like super fit at max, someone who's super unfit, they're both going to have the same max heart rate, generally. So the thing that we can really like train and improve is stroke volume. So there's 3 variables that we're gonna that we can use to determine stroke volume. So end diastolic volume or preload. I actually really hated in my like PhD. In your PhD, you have to do the comps where you have to memorize all this stuff, and like I really hated this. And then one day I had like an epiphany where I just understood it, and I realized they're not scary. So preload and afterload scare you. Don't be afraid. We'll explain them really easily right now, hopefully. So preload is end diastolic volume. So the volume of blood in the ventricles, you guys are going to judge me for thinking this is really confusing, which represents the volume of the blood in the ventricles at the end of diastole. So the heart has pumped. It doesn't go down to 0 blood sitting in the heart. You've still got some blood in there. So there's a preload. Before the heart contracts, there is a load of blood in there. It's preloaded. So we have something real fun called the Frank-Starling law of the heart, which predicts that the strength of ventricular contraction, because remember it's the left ventricle that's going to be pumping that blood through the whole body, that the strength of ventricular contraction increases as preload or end diastolic volume increases. So let's say here you've got your ventricular end diastolic volume on the x-axis. Stroke volume over here on the y. So you're sitting here at whatever this is. I don't know. So there's a volume that's hanging out inside the ventricle, and then you end up getting that stroke volume. Again, it's smaller than the end diastolic volume because we're not pumping everything out, as I said. If you increase venous return, and at the end of diastole, so the heart pumps, you've got diastole, the ventricle is filling, so it doesn't squeeze everything out, there's some left, but then it's also starting to fill from the atria, there's venous return coming back, ventricle's filling, getting ready to pump yet again. The more blood ends up inside that ventricle at the end of diastole, so end of diastole is right before systole, right? So right where the heart pumps, the more blood that you've got there, the harder the heart is going to contract. So this is where all of my like whoopee cushion analogies don't really work, because this is something in the heart where you can picture it's increasing in volume, and it actually has to do with stuff that I used to be able to tell you about, but I think this covers like Darren's lecture about like the cross bridge attachments and stuff like that. Basically, you stretch the heart and everything ends up in a perfect little way that as soon as you depolarize and start the action potential, you get this massive increase in contraction, as well as some elastic recoil. So just the fact that these are stretchy like a balloon. So as you increase this volume, you're going to have an increased force of contraction. And that's the Frank-Starling law of the heart. So just by increasing venous return, getting more blood into that left ventricle right before you contract in systole, you're going to have a stronger contraction. The strength of the contraction is going to increase as your end diastolic volume increases. Does that make sense? Oh boy. This is embarrassing. Okay, so increase in, and this is just what I just said, but actually much more accurate with more detail. So it lengthens the cardiac muscle fibers, increases the number of actin, myosin, cross-bridge interactions, calcium sensitivity of troponin C, velocity of cardiac muscle fiber shortening, so you get a stronger force of contraction. Oh man, are we on the same page here? What? Okay, increased stroke volume. Who loves preload now? Huh? Easy. Is anyone confused still? Was anyone ever confused? Maybe it's just me. Okay. So again, end diastolic volume is determined by venous return. So if you don't have blood coming back to the heart, so venous return, then you don't have blood going into the atrium and then into the ventricle. So this is completely determined by venous return. So if you have venoconstriction, which is a decrease in the venous side, blood flow through the venous side, then you'll have an increase in venous return. So sort of like pumping blood back up. And speaking of pumps, the skeletal muscle pump, which is one of my favorite things, compresses the veins and pushes blood back towards the heart. Does anyone have low blood pressure and like passes out or almost passes out? Nobody? Get out, nobody? Oh, I got really low blood pressure. So have you ever seen those? It's usually women. A lot more women have low blood pressure and tend towards fainting than men. And you can sometimes see videos of this. There's some really cool like space-like videos, but of royal guards like at the palace, like at the Buckingham Palace, who are standing at attention. And the idea is they're standing there and slowly their blood is just like pooling in their lower body. And if you ever, no one has low blood pressure, but anyway, if you just weren't telling me, and you secretly do, if you have to stand still for a long time, like if I stand for too long, I will like straight up pass out. So I walk around, because what you're doing when you're walking around is you're activating your muscle pump, and your leg muscles are pumping blood, because veins have all of these valves in them. If you come to my lab, you can see them on ultrasound 2 times. And so you activate your muscle pump, and so it's going to pump blood back up to the heart, and it assists with venous return. So sometimes if I have to stand still for a long time, I'll like do kind of like the leg cross and stuff like that. If you catch me like on a treadmill, which is kind of rare, but like especially I start to feel real lightheaded, so I'll do a lot of like moving my legs around and stuff like that to try to pump blood back up. I shouldn't be standing still on a treadmill, but like sometimes I have to hop off on the sides. Anyway, okay. All right, so, oh sorry, where were we here? I got distracted by my fun exercise stories. So stroke volume, you've got preload. What about afterload? So afterload, in order to eject the blood, you need to exceed the pressure that's in the aorta, basically. So the heart's not just pumping into nothing, it's pumping into your blood vessels. I think it makes perfect sense that like you need to have a higher pressure inside the heart than what's outside the heart, otherwise it's not going to go. So that's afterload. That's the pressure that's just outside the heart in the aorta. So as blood pressure increases, as mean arterial pressure increases, stroke volume decreases. That makes sense, right? Because now the heart has to pump against it. So you can increase your contractility. You can increase your afterload by sort of like increasing the whole loop, increasing venous return. But at the end of the day, every increase in blood pressure that you get is making it harder for the heart to pump against it. So if we look at afterload here on the X and stroke volume on the Y, so as afterload increases, stroke volume's coming down. This is a healthy subject with normal left ventricular function. So for a while, you can stay at sort of this nice plateau, so you're increasing afterload, but stroke volume, you can compensate, again, with like increased contractility, and you can keep stroke volume relatively maintained, which is good, because in exercise, you don't want to just be, your stroke volume to be crapping out on you. But eventually, it's going to come down. But if you have like a heart failure patient who has left ventricular dysfunction, who's unable to sort of fight that increase in blood pressure, then stroke volume starts to go down. And again, this sort of goes back to whether you're going to have a big VO2 or not, depends on your cardiac output, which is going to depend on your stroke volume. Number 3. Again, I'm stepping on my own toes here, but myocardial contractility enhanced by increased sympathetic stimulation, parasympathetic, no change in contractility, sympathetic, increased force of contraction. And so you can get increased sympathetic stimulation, which is going to release norepinephrine right onto the heart. Increased circulating catecholamines, so epinephrine and norepinephrine, coming from like the adrenal glands, for instance, so they're circulating the blood. So that will increase your contractility. And then that will increase entry of calcium into the cardiac muscle fibers, yada yada. So again, here's your ventricular and diastolic volume, here's your stroke volume. So as you got, again, this is our preload here, as this is going up, we'll have an increase in stroke volume. And then during exercise, I want to say, we can increase this a lot more by increasing the contractility through sympathetic stimulation, which is going to act directly on the heart to increase that contractility. Or through the circulating catecholamines. Yeah. Good? Good. Oh, it's done. Okay. So, that is that. Does anyone have any questions that I'm guessing I know what the answer is, but does anyone have any questions that they want to say to the group? I guarantee you, if you have a question, someone else has that same question, and it's probably something I explained poorly. If not, I'll be here. I do have a meeting at 11:30, so I'll stick around for a little bit if you guys have questions. But yeah. Oh, yeah!
What's the format of the midterm?
Oh, that's a great question. Oh my god, sorry, yeah. Multiple choice, true, false, short answer. Yeah. Yeah.
Is the short answer going to be like a question and we answer the paragraph, or it'll be like...
Yeah, like sentences. So it's like provide 3 brief statements of this. You don't have to answer in like an essay. So they're each worth like, I want to say between 3 and 5 marks. So tell me something about this, you know. So we give you like an effect or something like that, and you have to give a detail about it. We ask for a detail. And usually, having seen the midterm, there's like a few different options, so you just have to name one of them. Yeah?
How many questions are there?
Yeah, that's a great question. I think it's at 60 marks, something like that.
60 marks.
Yeah.
With 30 questions.
Do you want me to, let me talk to them. Do you guys want this all? You guys want this information, don't you? How about, we'll send out an email. Can you remember to do that? With the midterm format. Was that going to be all the questions? Okay. Good job. Okay. Good luck when you're studying. See you guys Tuesday.